Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening, everyone, and welcome to Pause for the Truth. I am Jocelyn Turner. It's wonderful to see. Okay, so is it me or is it the to-dos is at 6:30, right? Just over my
Yeah,
face.
yeah, it's over here. Yeah,
Laughing.
yeah, Tyrone, he dogging you out.
Oh, there we go. But anyway, being silly tonight as the thunder. I don't know if you all can hear the thunder roar here where I am, but the weather is about to get, I don't know what's about to happen. So hopefully it won't affect my connectivity. But thank you all for joining us tonight as I start out being silly on this Tuesday evening. Welcome to Pause for the Truth. I am again Jocelyn Turner. As always, we have such a very important topic that we want to talk about. And if you can recall, last month, we started a series on I'm sorry, Dr. K, how come you didn't reel me in? Like, wait a minute, wait a minute.
Well, look at it. Tyrone said that was going to be me, but go ahead.
Forgive me tonight. I am really all over the place. I must, of course, acknowledge our co-host, Dr. Rogers Kane. How are you doing this evening, Dr. Kane?
I'm doing just fine.
And we are pleased to have Dr. Shirley Jones with us tonight, as well as Dr. Kenyatta Lee. So happy to have both of you with us this evening. How are you doing this evening, Dr. Jones?
Doing great.
And Dr. Lee, you're muted, but we're ready to hear what you have to say. Welcome, and how are you doing this evening?
Unmute yourself. There you go.
All right, I'm doing great. I'm happy to be here. It's great to be here.
Wonderful, wonderful. Well, we are continuing our series on the future of healthcare. Dr. Kane, for those of you who may have seen the show last month, Dr. Kane introduced or gave you all a sneak preview of the topics that we'll talk about within that series, the future of healthcare. And tonight we're talking about value-based healthcare. Now, you may be wondering, as I was before I did my homework, but since I am not the one in the hot seat, I'm not going to tell you what value based healthcare is. I'm going to pitch that out to either Dr. Kane to lead in. Dr. Kane, I think I'm going to start with you first. Why did you feel it was important for us to talk about value based healthcare? Now, I don't want you to answer all the questions in that answer. We want
No,
to give that.
I'm not going to attempt to answer all the questions because I got two people on here a lot smarter than I am. So one of the reasons I chose value-based healthcare is if you recall in the last session, we talked about fee for service and the current model that it isn't working, that it's too expensive. We talked about the amount of what we call a GDP, how much it was the GDP, and it was 18% of the GDP. And for anybody that's interested, that would be uh, 4,102 billion. Now, let me back up. And billions of dollars is 4,102. So they go past trillion. What's coming after trillion? Quintillion or something like that. Whatever that is.
More than my bank account, that's for certain.
Right. But anyway, long story short, and we emphasized that it wasn't going to work as well as it wasn't going to continue to work in this society. We have forgotten reign in healthcare. And when we kind of left, the last word was that, we need to look at a system that provide greater time and focus on physician and patient interaction, interactional relationship, while also giving a better product in return. But that's one of the reasons, because if you're going to switch from fee for service what are we going to go to? And so value-based is what they came up with. So my two guests, you can go ahead and ask your next question.
Thank you, Dr. Kane, especially for that lead in, because I know this might be a topic. One of the things that COVID brought about, in my opinion, is people learned about the healthcare system more than they ever thought they would because of COVID-19. Now we have a lot of what people I call street scientists, because they think they have all the answers. And unfortunately, they're not always listening to the three of you and your wisdom and knowledge and all of your research. But they're going to listen tonight, because this is a very important topic that we just don't know. You know, sometimes they say you don't know what you don't know, and you don't know what might affect you in the future. Dr. Jones, I'm going to start with you. What is value-based healthcare, and why is it important for us? No, let's just start with there. What is value-based healthcare?
Well, I'm going to defer to Dr. Kenyatta Lee, because
Okay.
he does value-based healthcare.
All right, Dr. Lee, you're in the hot seat.
You know, I thank you, Dr. Jones. Thank you, Dr. Kane. Thank you, Ms. Turner. I think it's just value-based care is really this idea that we would, it's a very technical definition. So value-based care is quality per unit of cost. So you're literally looking at how much quality can you get for the amount of money that you spend, and it's care, that business model that compensates physicians and healthcare systems for producing increased value. So more quality for less cost, and it's connecting compensation to outcome, which hasn't really been done in our business model. So we're 20% of GDP, 18% of GDP, and that's one of the biggest trillions of dollars. But there is no mechanism by which the people who pay for that care are guaranteed an outcome that is consistent with the money that they spend. So there's a disconnect, and almost every other segment of our economy has that expectation that if you buy a car, you want to have great quality for unit of cost. You buy anything, a phone, computer, anything that you buy, a couch, everything is rigorously managed like that. And that's because healthcare is complicated, and doctors are hard to, and it's so many moving parts. As you look at Amazon recently getting out of the healthcare business, they sold their Amazon Care business. You have Bezos and and Buffett and those guys, these brilliant guys who were going to change healthcare, and they were not successful. But it's moving our healthcare model to a different way of thinking about care.
So that means if I am compliant, then if I'm coming to you, Dr. Lee, Dr. Jones, if I'm your patient and I'm coming to you, and we talk about, if I'm understanding you correctly, and you tell me, unfortunately, Ms. Turner, you have high blood pressure. So then you're going to talk to me about how to manage my blood pressure. And so if I then follow all of your advice and magically my blood pressure goes down, is that an example of value-based healthcare?
That's a great question. So most of the value-based care healthcare phenomena happens at the level of the contractor. So it's usually contracting for specific outcomes. The answer is yes, but typically you're not going to pay me more for a better outcome. It doesn't so much as the patients aren't always aware of the value-based care dynamic. Mostly it's the payers, and the contracts are based on how they reimburse you. They either reimburse you more or less, or they don't include you in their networks based on your outcomes. So they're looking at how do you measure good care? And that is really what people have been the dilemma, right? So they have the triple aim. CMS comes up with this idea called the triple aim, and they call it patient experience, quality, and cost or utilization. So, actually blood pressure is one of the metrics that they track. They have over 300 metrics. And the BP metric is it's called CBP, controlling blood pressure. So yes, if you are in my practice and you have a contract with your insurance payer, and they will actually compensate me at a higher rate if your blood pressure is controlled as a population. So they look at an average, they set benchmarks, comparing me to other physicians, and if my blood pressure is within that range, that for that population, then they pay me more based on that, and I can contract with them, which is, it seems obvious that it should be our goal, but that's not always been the case. It's been, doctors can do a bad job, not that we do a bad job, but the outcomes may not be what we want them to be, but we still get paid the same amount, which is not happening in any other sector of our economy to that extent.
Well, one of the things, just to add to that, one of the things that we used to call this pay for performance. That was its predecessor. The ideology is the same, and that is they're going to pay you based on what the outcome of your treatment is. And if you don't have a good outcome, then you won't get paid. In some cases, you won't get paid. In other cases, you might not get paid as well while they're implementing this new system in. My question to you, Dr. Lee, is, there's a lot of talk about value-based healthcare and exchanging it, from fee for service, so that we can do make sure we get patients greater satisfaction, greater doctor-patient interaction, yada yada yada. But they don't really tell you how to implement it. Is the question. So, any advice to some of the physicians out there how to implement it? But even though we want to make sure the general public is informed in terms of layman's, them understanding what we've got off. But just for the physicians out there, if you can.
I think it's a great question, and I'll keep it short. I think the options are, we have in our office, we have you have front office, which is everybody gets it. They answer phones and they make appointments and stuff like that. Admit patients, discharge them. And then you have the back office, which is where the MAs are doing their thing, EKGs, phlebotomy, and stuff like that. And then we have what's called the side office. And the side office is where you have your team that does population health management. The truth of the matter, Dr. Kane, is that it's really hard. It's hard to make a better car. You got you started with a bunch of car companies, and then you look at the 21st century, early the 20th century, you had a major reduction in that number of companies because the complexity of making a car that only, that you can do so at a good price, that's also safe and efficient is really difficult. There are a lot of ways to do it. Set up your side office. There are a lot of quality improvement opportunities and collaboratives, and there's a ton of literature out there. It's not, there are MSOs that if you have a contract, there's one way to do it. If you have a contract with a payer, they can come in. Their job is to kind of like to be a big brother that kind of helps you along the path. So what they have is a ton of pebbles that are designed to kind of get you interested in understanding and even the fee schedule is designed to support an evolution towards value. So it's a lot of moving parts, Dr. Kane. It's a lot.
Right. So, but then the other thing in terms of trying to, from a patient standpoint,
yeah.
Dr. Jones, I think before the program we talked about a little interoperability in terms of, for patients, you can tell them what that. I mean, for the layman, you tell them what that means of the computer system interoperabilities, and explain. Can you tell them how that might benefit them in terms of the new system?
Okay, so as far as I'm concerned, I don't do value-based care.
Right.
I do direct primary care, which is a totally different model.
Yeah, but my question is, because you do direct primary care, which we can explain to the patients what it is in a second. Because you still need to know what's out there regarding your patients. Having access, ready access to other computer systems, their information, for you to be the best at providing that care. Would you?
Right.
Okay.
So the thing is, you mean like access to their electronic health records?
Right. Each one of them can talk to each other, that kind of stuff.
Yes, each one of them can talk to each other. If the physicians remain on staff, like courtesy privileges, you have access to the different hospitals' systems. A lot of the hospitals have now converted to Epic, correct?
Yeah.
And so
Yeah,
you're
very
able to,
expensive. Very
right.
expensive system. But go ahead.
Yeah. And so it opens up a door to, we can communicate back and forth. If
Right.
you know, as a physician in the community, if you stay up to date with the other hospital systems.
Right.
And then so you can, and then with specialists, you know, it's just a matter of electronic health records, requesting records and so forth.
And Dr. Lee, that's pretty much some of the things that same thing you be looking for, right? Nothing much different.
I think for me, you mean in terms of how we use our EHR system, electronic
Yeah,
health record?
how you use the EHR system, and in terms of being able to take very good care of the patients, provide better care. Because remember, that's one of those benefits is supposed to provide, decreased cost and increased time interaction with patients, yada yada yada.
I think that point is an important point. I like because so using data makes a huge difference in value-based care. So informatics and sharing information, it's so funny that you bring it up because I think like God that we did this the last 4 or 5 years because we can share records, and I'm sure all of us have been in that space where you hit Commonwealth and it populates with all the goodies from Baptist or St. Vincent's. I was sitting there talking to a patient today, and I could go back. She had a stroke or something, and she was in the hospital, and I could go back to 2005 and look at her records and say, well, now you're having this weird sort of presentation. She was having pre-syncopal episodes related to bowel movements or micturition, which was kind of interesting. So this pre-syncopal presentation, but I could see that she had AFib. I could see that she'd had this before. It allowed me to make a decision where I couldn't do it. I love the way healthcare is moving, to be honest with you. And then and that sharing of data between systems is hugely something that, and to do value-based care in terms of utilization management. I had a guy just called a few minutes ago. We sent him to the hospital. I saw back in 2011 that he was in the hospital. He was anemic. It was 10.2. Now he's 6. This is not the first time you've had this. I'm sure you're aware of it.
Yeah.
Let's make a move and do something about it.
It's just how quickly we can have access to some of the information, because that old where you got to fax stuff in and all this PDF crap. That doesn't make any sense. Interoperability, computers talking to each other is the only thing that's going to make this a lot easier and a lot more efficient than what it is.
Well, it's funny. It's funny you mentioned that, Dr. Lee, because I had a procedure done recently, new doctor, and when I went to them, in preparing for the procedure, they gave me a list of everything that's happened to me, and I thought, like, well, how did she know that? I didn't share all of that with her, But the beauty of it is, it showed all the vaccines I've had in terms of Hep B and all those things that I had while I was at the health department. So I was so now light bulb just came on. Oh, that's why that happened. And because I wondered, like, well, how did she know that? I didn't tell her that. And that was going to be my question for all of you is, we talked about, Dr. Kane asked, all the ins and outs stuff that I obviously have no clue about because I'm just an outsider, if you will, and not a clinician. So how does value-based healthcare, how will it help me as a patient? How am I going to be benefited from it? And should I not feel rushed by you all and as though you're on a time limit when I come in to see you?
Ms. Turner, before anybody answers, I think it's the perfect time for Dr. Jones to talk about direct care, which is one of those offshoot. I'm gonna say offshoot, but still part of value-based care. Still part of value-based care. It's one of the components of value-based care. Okay, even though it's more voluntary, but she can tell you more about that, and then she can answer the question you presented because that's where she's at. That's her space.
Okay, so with the response of how insurances are dictating patients' health care and dictating how long doctors see patients in organizations, there were a group of physicians that pulled out of all the insurances, and they invented or came up with a new mode of care, which is called direct primary care. And what it is physicians that are private, and they offer a membership-based practice, which is more like the old days, where your physician is your physician. There are no intermediate people. You direct your relationship is with you, is the patient and the physician. You keep your costs low, so that when you set your membership prices, you're only paying one staff member or at the most two staff members. And all the money is, you include the patient in their health care. So when you work for large organizations, your panels of patients may be anywhere from 8,000 or more, which limits them, means you have to see people every 15 minutes, every 20 minutes. And all of these things are set by the organizations and, all the powers that be. Whereas in direct primary care, you decide if your patients have anywhere from 45 to 2 hours for a visit, and you decide, you get a certain panel of patients that you can handle, and you become, a relationship. You become part of their family. And so with this, they pay a monthly fee. They can still use their insurance if they want to. If they don't have insurance, they can use it. They can just pay the membership, because with the membership, there are no co-pays. You have direct access to your physician. A lot of direct primary cares have actually pharmacies, and they dispense medicines, and the medicines are very cheap because they get them wholesale, and you can get them directly from your direct primary care. You also, a lot of times when you go to get x-rays and labs, they upcharge you because of insurance costs. But when you directly make a contract in a direct primary care with these organizations, an MRI may cost $60. And so we pass
discounted prices, is what you're saying.
They are private
prices.
Right. But they are strictly for DPCs, direct primary care. Because a lot of the prices are cheaper than the self-pay prices. They actually contract with us. And so with that being said, that's how the direct primary care is actually starting to help with providing health care for people who can't afford insurance, or who can afford insurance but feel like, I don't want 15 minutes. I want to take time where my doctor sits down and address everything. And so you don't have to say, well, you can only address 2 things now, and then you got to come back, because your visits are unlimited. The labs are usually included. It's very how much anything that's above and beyond the membership. And so the memberships are set by the physicians, what they want to include. And so you just pay it monthly, and it includes, most time it includes your labs, it includes your physical exam. Some people put in immunization, some people don't. Some people, it includes 2 other visits, unlimited telehealth.
Oops.
It's very transparent.
There we go.
You froze, Dr. Jones. So how do I determine if I have insurance, or if anybody's listening right now and they said, oh man, where is she? I need to sign up for her. I mean, and they have insurance. What do? Get rid of their insurance, and we're about to go into open enrollment. Do I need to keep my insurance and sign up for a direct primary care? Well, how do you make that decision?
So what they have to do is sign up for a PPO, or a high deductible plan, which allows them to go to whatever physician they want to go to.
Okay.
If you sign up for HMO, you only can go to the physicians that are on their plan. So most of us, like myself, I pulled out of insurance, period.
But they can have the HMO, and if they want to pay your fee on top of their regular insurance, they can still have you oversee their medical care. Is that correct?
But no, not really, because the thing is, I wouldn't be able to order any labs.
Understood.
Because it is an HMO.
Yeah.
So then if they want me to oversee it, I charge a consult fee as opposed to a membership, because a membership, yeah, you know, why charge them if I can't do anything for them? Yeah.
Right. Got it. But you will charge them consult fee for them to come in and spend whatever amount of time they need to go
that they want.
Okay.
Yes.
Got it.
And so they can reach me. It's St. John's Direct Primary Care.
Got it. Okay.
If you Google
That's
that.
right, Dr. Jones. Do a plug for your business. I'm not mad at you. So let me ask you all a question, because as we were preparing for today's topic, one of the things that it talked about is, and Dr. Lee, this might be a question for you. I'm going to read what it says. It says, a healthier population with fewer claims translates into less drain on payers, premium pools, and investments. Value-based payment also allows payers to increase efficiency by bundling payments that covers the patient's full care cycle, or for chronic conditions covering periods of a year or more. What does that mean? Did I just speak Greek to you? Like, I don't know, send me the article.
You're muted, Dr. Lee. Dr. Lee, you're muted.
Tell me the first part again. What was the first part?
The title of this, it's under the title of Payers Control Costs and Reduce Risk. And so it says risk is reduced by spreading it across a larger patient population. Mm-hmm. A healthier population with fewer claims translates into less drain on payers' premium pools and investments. Value-based payment also allows payers to increase efficiency by bundling payments that cover the patient's full care cycle.
So the first part was just describing the risk pool and how they think about a population. So you have a population of 1,000 people, and the bigger the risk pool, the less likely a catastrophic event will push you into the red in terms of your financial position. So you're always thinking, here I have a pot of money. If I have a small pot, 10 people, and I have a congestive heart failure or MI or a brain cancer or something complex, that risk, I'm at greater financial risk in that small pool. If it's a bigger pool, then it's less. If you control costs better, meaning reduce utilization, which is one of the sort of metrics that you use to measure success, then you control the value, the proposition to payers is better. So you have two populations, or three. You have the commercial group, which pays about 50% of the bills in the country. So that's the sort of standard piece. Then you have the social payers, which are Medicare and Medicaid, and you throw in the marketplace piece, which is what people call Obamacare. And each of them has a different issue. The payers that are self-insured, they pay dollar for dollar. That means when a large company, you have a claim, they pay for it out of their pocket, almost dollar for dollar, and they don't have a TPA or whatever, or somebody to help create the veneer of, I have insurance and this is the company. And really they're kind of like the middleman. And so, I think the logic is that it's better for the country when you can control costs and you're focusing on outcomes, using, and what you have is a fee-for-service system that is created that drives utilization. That, the more you do, the more you get paid. So guess what? We do more things that we get paid a lot for. So you look at the systems, you see massive health systems and usually hospital-based anchored systems where the margin is. So I can get into a long discussion about it, but I think ultimately it's just better for patients whether it's a DPC model, which I think is a really smart model, or a value-based care model. And I think, to your point, Dr. Kane, I think it is an extension of that. You get the patients would be wise to find. I told my wife, I said, Dr. Jones should be your physician. I mean, that's the type of concierge medicine you want. Right. That's how you want it. And when value-based care works well, that's ultimately what you get. And I'll tell you a secret. It's about eliminating disparities. Ultimately, a lot of this is designed to force a forced function to force me to care about patients and to love them in ways, because now my success or failure is aligned with their success or failure. If they can't eat, then they're hungry, they're going to go to the hospital. That comes out of my pocket. So now I need to work with them to think of them in a very different way, and all across the board. So I think we're moving in the right direction. And I think for patients, it really is a good way for us to think about healthcare and looking for physicians and systems that are good at value-based care, because there are those that are really good at talking about it,
Right.
but not really executing on the promise of what it can produce.
You know,
Hold on, Dr. Kane. I want to remind our listeners that they can call in now as we talk about the future of healthcare and value-based healthcare. The call-in number is 1-888-669-1280. And if you're just chiming in, value-based healthcare is a healthcare delivery model in which providers, including hospitals and physicians, are paid based on patient health outcomes. So if you just chimed in, you may have heard Dr. Lee say, if his patients are sick or not eating, then guess what? He won't either, right?
Right.
So
and
that's
soon
what
will
we're
be
talking
sick.
about. So he wants his patients to
And
be,
soon will be
as
sick.
as
Yeah.
doctors, and this is not to say that, doctors never wanted their patients to be healthy. They don't want them, one of my friends and he's been a former guest on here. He used to tease me at the health department. He's a funeral director. He said, whoever we didn't take care of, he would. Now, of course, I prefer to lean on the side of you all than him, quite naturally. But go ahead, Dr. Kane.
So just a couple of things I want to point out. Both of what these individuals are discussing is more of a personalized healthcare, an individualized healthcare model. That's basically what we're looking at. Some involve insurance payers like Dr. Lee, who's leaning more into the payer side, but it's still value-based medicine because his outcomes have been tremendous. I can speak for that personally. And then also with Dr. Jones, whom has patients that are more direct care, you pay more for the services out of your own pocket in terms of getting the personalization, a personalized service that you give. And maybe you don't pay more, because if she gives the correct guidance, then what she's actually doing is saving you from paying out, going to the emergency room maybe, or the added cost of your uncontrolled diabetes because you ain't paying no attention to it, or whatever it may be that they do. The other thing is they both represent a patient home, a patient medical home, and by the two models that they're discussing. And so I want patients to understand that both models come up under the, as Dr. Lee said, come up under an umbrella of value-based healthcare, and that it is, like I say, pay for performance. I mean, if you don't do well, like Dr. Lee says, if you don't do well, then physicians don't get paid. Now, not all physicians are in agreement with Dr. Lee that value-based is the best. As a matter of fact, I think it was like 53% said, doing one survey, said they would rather keep fee for service. But that's because they old farts like me, more than likely.
And I would tell you too that it works if you're in an environment in this part of city where you can make a difference. When you're practicing on the west side where there are food deserts,
right?
Because I did practice on that side.
Yeah.
Value-based care is not good for that area because you're being held to standards that you can't make a difference. Because your parents are they're passing by the Dunkin' Donuts, they're passing by everything you can possibly should not be eating is on 103rd.
Well, yeah. I mean,
and they would pass all those things to come to my office.
Cholesterol roll on the north side is Dunn Avenue, just like
there you go.
103rd where you're at. But
yeah,
I'm gonna tell you, because of my knowledge, I think Dr. Lee might disagree with that statement or have some. I ain't gonna say disagree. I let her speak for herself, but I think he has some commentary on that statement because if anybody's in the hood, Dr. Lee is in the hood. So, and he has a value-based model. Go ahead, Dr. Lee.
I think I don't disagree. I think you're fighting the epidemic of diabetes and hypertension and obesity.
Right.
And it's not fair, but who said life was fair?
That's true.
For not me, fair to physicians, you mean?
What did you say, Dr. Kane?
Not fair to the physicians, you mean?
No, it's not. It's not. Okay. And you would hope there are times when you look at it, you say, well, if you did the model in like a suburban space, it would probably, your outcomes would be better, it'd be easier. The no-show rate would be lower. Your less depression, less comorbid conditions that complicates your outcomes. But the reality is, this is where I think the social payers are more sophisticated in how they structure it. There's more discipline around what they're expected to do. A lot of it comes, to be frank with you, comes from the federal government. The federal government, it drives policy. This is 20 years of people fighting to produce something that says equity is important, outcomes matter, some responsibility around cost. The funny thing is, this space is as partisan as anything could be. So value-based care in an urban setting, to your point, Dr. Kane, this is the hood of the hood. And to your point, Dr. Jones, there is nothing, it's like a desert if ever there was a desert, dry as dry can get. And when it comes to nutritious foods and things that they could do and places to walk, and we could talk about that, but most value-based care models are thriving in urban core environments because the sort of the financial push to make it happen is there. So you have CMS saying, look, Medicare has to reduce costs, it has to bend the curve. And the good thing is when we push this way and the Medicare and the Medicaid space, it spills over into the commercial payers and people start talking about DPC and stuff like that. So I think, it is hard. And it's a lot of physicians will say, well, that's if you think front office and back office, you can't do value-based care because that's not it. And the staffing that I have is like really significant. We have to staff up. I have people that don't touch patients. I have a woman who said, well, I saw the room full and then the room was empty. I'm like, we were working hard. We were chopping trees and digging, we were throwing, eradicating. The phone was ringing. And she's like, I didn't, and she's in the side office. Her job is to focus on the metrics, interact with the plans, close gaps, send supplemental data, all that kind of stuff. So I think it's a great model for urban core environments. And a lot, to your point, physicians, it's a reshuffling of the deck. The funny thing is that the pendulum is swinging. The amount of money they put in the system is not increasing. And what you have is if you're a specialist and you're going to be impacted by this model somehow, and probably in a way where you're going to see the pressure for decreased utilization and maybe even a bit financially, you may feel it. You may not. I don't know. It just depends on what you do. But you may feel it because you're basically saying we can't keep wasting resources for people you're doing all this stuff. And it's amazing. It's better care than anywhere in the world, but it's still not necessarily the right care. If they had gone to see Dr. Jones and she could tell him, hey, eat this, stop the cookie cake and the cookies and and if you could do that over a period of time, you know what I mean? You just don't have the waste that you see that comes in the system. And so much, 33% of what we have in healthcare is considered waste. So you got a $1 trillion budget, $3 trillion budget, and you have 30% of that. You're like, where is that money and how could we use it to pave some roads, to buy some books? I don't know.
Well, 30% of what you talked about, I know 18% when it was back in 2018 or something like that. 18% of what it was in terms of healthcare and what was being spent was, the half of it. And one time they predicted that half of what we spent was going to waste, and that half amounted to $4,000 billion. That half is actually half of that, $2,000 billion. And when Dr. Lee talked about metrics, what he's talking about is measurements by which CMS, Medicare, or other healthcare agencies, measures of which we have to achieve, like a controlled blood sugar, controlled blood pressure, other things, a whole lot. How many metrics is it? Is it 400 and something or something like that?
You got to stop leaning in. We can't see you when you lean in.
400 and something.
HEDIS sells them, and they make new ones every year.
every
They have
year.
a metric for everything.
Every year you're measuring every output. But what it does highlight, and I'm going to pose this question to you guys, what it does highlight is the need for analytics, for data, the need for data, because that is the future, which we will talk about that in an upcoming series, exactly how that data is going to be achieved. But having that data and being able to take care of people other than in fee for service, one of the things we see a lot of is an algorithm on how to take care of patients. Here's an algorithm. You need to implement it, because you only got 5 minutes to talk to the patient, 10 minutes to document what they said, so the patient, the time you spend with the patient ain't but about 5 minutes. Unless you take your work home with you and you're doing it after hours. The bottom line is the more we know, the better we will be able to develop medicine, because most studies and things of that nature ain't modeled after us. So those recommendations can't be what's best for us. And so people on the front line like you guys are going by your life experience and your own self-analysis at this moment in time. But that's going to change too.
Right.
So doctors, how are patients going to benefit from all of this change? What should they expect to see different? And Dr. Jones, you talked about the direct what is it? Direct primary care. Right. So Dr. Jones, Dr. Lee, how are patients going to see, or what's different now than it used to be in terms of the way you are providing care for your patients, other than the back, the side, and the front office?
Dr. Jones, you wanna come in, and then I'll finish out.
Sure. So with direct primary care, we find that we are able to spend the time with patients to educate them more, to help them make the right food choices, because we all know as physicians that the majority of the illnesses and diseases that people have are self-inflicted. And so a lot of these things can be changed without medications. But if you're not given a right amount of time to see a patient, to dig into it, because a family, you can't say everything's genetic, but some things, behaviors are passed through families and generations. And so correcting one person in the family is not always the answer if they have to go back home and deal with a husband who eats pork ribs, and every time they have a party for somebody's anniversary or birthday, they're having bacon and all of this stuff. So it's overall teaching and educating the entire person and their environment, and teaching them how to live in their environment and what else they can do to help themselves, putting their healthcare back in their hands with my helping them.
But Dr. Jones, before you chime in, Dr. Lee, Dr. Jones, here's the first thing I'm thinking about when I was working and choosing what health insurance that I wanted to get. People were always saying they couldn't afford PPO, so they leaned towards HMO. For Dr. Lee's patients then, because he talked about being, and you referenced food deserts and low-income communities. Persons from low-income communities, I can't see that they would be able to afford direct patient care, primary care. Is that then when they would choose, and I'm assuming, because I'm still learning, there's a difference between direct primary care and value-based care, what Dr. Lee is providing?
Right. So the thing is, if you look at the overall cost of the system, if you have more direct integration into a person's life, the healthcare dollars spent go down. Okay. And so we don't charge per visit. It's a monthly fee. Most time it's less than someone's cell phone bill.
Oh, wow.
And it's a monthly fee. And so even if you decide not to get health insurance, you could use just a direct primary care and pay that monthly fee, and you can get health care.
What happens when you have to have surgery?
Then what we do is Right. So we contract with certain specialists, and then there are different ways to get your surgery taken care of. There are programs that are run like by some of the Christian. I can't think of the name of the. They're like it's a bunch of people get together and they pay this insurance for hospital coverage. Do you all know the name of it? They pay hospital coverage, and then if they need it, it's like they will pay. And to join that is only like 80 some dollars. There
Yeah,
are ways to get
I've
all of
had a
this.
patient.
You know what I'm talking about?
I had a patient that was a member of that, and when they needed some help, they did ask them. But that's not a guarantee for everybody. That is a. I personally would not. I want to make sure patients have some alternative mean by which to cover them from a financial standpoint. The direct to primary care is an excellent model, but the only thing is for people who can afford it. And there's nothing wrong with it.
Actually, because if you think about what your co-pays are, the average person's copay is $40, $50 every time you go to the doctor. Mm-hmm. And that's not including according to what your insurance that you have. It could be Obama. Well, it's not Obama, affordable health care. Yeah, but it may be. And so you still pay a percentage of whatever the visit was, because the cheaper ones, you still have to pay a percentage.
The quality of care, I'm not comparing the two. What I'm comparing
but the amount of money
you make a diagnosis. What my concern would be when you make a diagnosis, with direct primary care. If you find something out for that patient, I know you're trying to do a lot of preventative, but in the case where it was beyond your control, some cancer or something, then that person is going to need care.
Right,
if they can afford, some health insurance, I encourage them to get it. Because the expenses that may go beyond what you can do and or advocating, I have a whole lot of spirit about making sure all people got served and all people got good health care. But ain't jackrabbit I can do but except mainly keep my family in it at the moment, because of my restrictions. So the bottom line is, I just don't want patients to walk away feeling that they can just go straight to direct primary care and have no financial backup, because they may run into some difficulties.
Well, no, that's not what I was saying. That's not at all what I'm saying.
I didn't want them to walk away and
whether or not they need insurance. Okay. You don't have to have insurance, but with you making that choice, you need to realize you don't have emergency coverage. Right. So you need insurance, but you just don't need to buy an HMO insurance. That was my
Okay. I missed that part. Okay.
Yeah. That's what she was asking me.
Okay.
Yeah.
All right, Dr. Lee, what am I going to see different now when I come to you, knowing that you have instituted value-based care in your practice?
So the biggest thing, I'll tell you the reality. So we are in a hybrid space. So part of our contracting is value-based contracting. Some of it's not. Our biggest contracts are value-based contracts. So we do a combination of the two. That's the first reality. What you will see in a really mature value-based care practice is, and I'll just be very frank with you, you'll see a better patient experience, which is, an intentional effort to make sure that everything that you do in terms of how you touch the practice allows you to walk away satisfied. That's what has to happen. There's a survey, a patient experience survey. There's CG CAPS, where you really have to make that the norm within your practice. So you're looking at cycle time, how quickly you get in, how quickly you get out. Are you listened to? Are you respected? Is the office staff professional and pleasant? Are you getting your referrals and all that kind of stuff? Is that happening the way you need it to happen? So that's that patient experience is there. The second piece is the quality. You will see a focus on prevention and all of the metrics that typically will fall within that space, and it spills over. So you're going to see You're going to get the phlebotomy. You're going to see a focus on your A1C. You're going to see a focus on your blood pressure. You're going to see a focus on DEXA scans and colonoscopies and mammograms. They're going to be low dose CTs and stuff like that happening. All of those metrics, PHQ-9s. There'll be more sort of annual wellness visit type activity where you may be called like a MOV or Medicare, and where there's this real sort of comprehensive review of your systems and everything that's going on with your psychosocial issues. So that's the quality piece. You'll find infrastructure in place to help you with things like hospitalization. If you get hospitalized, there's probably going to be a case manager who's going to call you and say, hey, we can see you went to the ER, you went to the hospital. Let me work with you to coordinate a follow-up visit with your primary care physician. So you should have more resources in place to get better outcomes and sort of making it possible. I think it's important to know, though, it doesn't happen magically. It's not without cost, even, to be honest with you. You have to be committed to and invested in yourself wanting to be healthy. The smoking and all that kind of stuff, all those things still kind of factor into what you can experience, but you're going to have a better quality of experience. It's to be frank, I think it's better care. And the focus at this point is really social payers, so Medicaid and Medicare, less so the commercial payers, although there are examples of commercial payers entering into sophisticated value-based care contracts. It's not, the commercial payers aren't doing it as much if you're in that space, but you can find people that are doing value-based care. But some of those people, to be honest, when I was in a practice in another city in the state, we actually discharged a bunch of our commercial payers because of our desire to just focus on our social payers. So there's no, which is kind of weird, like who would give up a commercial payer? But the reality is your margin is so much better in the other situation. So my theory is that you would have a better experience than the traditional practice in terms of how you interact with it and what you get from it.
So open enrollment, thank you. Open enrollment in many instances for many employers, I know since I was a state employee, is going to happen soon. So people are listening to this show tonight, and are they going to see direct primary care on a list of options? Are they going to see value-based care on a list of options? Or are they still only going to see HMO or PPO? And how are they going to know what providers offer direct patient primary care or value-based care?
Dr. Jones?
Well, you have to, that's one of the things about educating the shows like this, about educating the public, to let them know that there are always other choices. So they have to take it upon themselves to actually do some research. You could Google direct primary care, and all of the direct primary care physicians and nurse practitioners that are in the area will come up. And you can, go around, make an appointment to talk to them. We all offer free consultation, so you can learn about the business and how much the fees are and, how much it'll cost you. We also help with, so it will not be on people's, because it's really not that many of us that are in direct primary care. So we have to do a paradigm shift for people to get in direct primary care. It's just not many in the Jacksonville area. Okay. So you won't see us, yeah. Hence, that's why I did the podcast.
Thank you, Dr. Jones. Dr. Lee, am I going to see value-based healthcare as an option somewhere on the list of options when I'm choosing PPO or HMO?
You will not. You won't. And it won't be obvious that that it is value-based care. You won't know it. You have to be incredibly sophisticated to know what you're looking for. And people choose me because they think I'm a female or that I'm Chinese. As you can see, I'm neither. So when people choose me, it's not as making sophisticated. They kind of will say, well, that doctor is just nice. Or, I heard he saw my mom and he did a home visit or something. And then they say, well, then they kind of bump into the value-based care space by accident. But most of the time it's not, and they don't I don't think the consumers, to be honest with you, should know. I can understand, in theory, all healthcare should be value-based in theory, but in reality, most is fee-for-service. And you can, and I always people say, well, I'm going to choose this or change this. And I'm like, okay. But because the resources and the structures and how we look at data and manage population is way more sophisticated than the traditional primary, what I did even 10 or 15 years ago. So you're not going to notice a difference. You may see things like PCMH or patient-centered medical home or something that says they did a little extra something to distinguish themselves, but that there's no guarantee there that that's a value-based care shop either. You have to kind of.
As both of you were talking, Dr. Jones and Dr. Lee, I'm gonna tell you the difference of who I think might be your patients, the difference between, and I'm not trying to, for the audience who's listening, I'm not trying to sway patients toward either of the doctors in any way, but as a working class person, I would think that they are more apt to choose direct primary care. But I see my mom and her friends going to Dr. Lee for value-based care because I would think that they have more needs. And again, I'm not trying to say that Dr. Lee is a geriatric primary care physician, but that's kind of how I see the difference. A healthier, younger population, not pediatrics. I just don't see them caring about the value-based versus, I don't know, I might be wrong. Versus
Well, I
someone
will
like,
let you know the majority of my patients are older.
really? That's great.
Yeah.
Yeah, and
That's
that's what
great.
I would expect. Be honest,
Because
with
they want the time. They have all the problems.
So I had
Especially
it backwards.
that younger crew you talk about, Miss Turner, they ain't thinking about they ain't sick. They omnipotent.
Right, they're
They
not
don't have
sick.
that.
That's true. That makes sense. Thank you
Yeah.
for clearing that. By the way, we have a question. Is there resistance in the medical community to join either model?
And well, that was something I pointed out earlier, that when there was a survey done, most of the doctors stated they wanted to remain with the fee for service. So, with that being in mind, yeah, there's resistance from the physicians. But let me say this: I can tell you, value-based care ain't no turnaround from it. Fee for service is going out the window. There's no option. We have no option. The main thing, main issues is going to be how's it going to be implemented. That's why I asked that question earlier. How's it going to be implemented? By whom and for what reasons? Now, those future healthcare, the future topics go right into some of that ideology on how it's going to be implemented with technology. We talk about technology. If you remember, just let everybody know the next broadcast, the Internet of Things, big data, and artificial intelligence, which is going to play a key role in getting the best value-based care. I don't care which model you're looking at, Dr. Lee's or Dr. Jones. You're going to need these items to be successful.
I agree.
So it's 7:30.
Mm-hmm.
And although, we can carry this conversation on and on, out of respect for each of your time and for our listeners, we like to stick within the timeline that we say that we're going to do, and we will continue the discussion in the series on the future of healthcare. As you're listening, you can tell that things are happening in spite of what we know that's happening. As Dr. Lee said, you may not even recognize it. You may not even know that Dr. Jones and direct primary care existed. But hopefully tonight you did learn some things. As always, we like to end our show giving our guests an opportunity to share their final thoughts. Dr. Jones, I'm going to start with you. What are your final thoughts regarding tonight's discussion?
My final thoughts are I'm glad we had this discussion and in place, because it lets people understand that from doctors' point of view, we are really trying to help the patients. And a lot of it is just lack of education, because if you didn't know, if we had not had this discussion in this place, a lot of people would not have heard of direct primary care because there's so few of us. And so I think it is from the Northeast Florida how we're allowing our community to find out about their options. And so that's what it is. We have options.
Thank you, Dr. Jones. Dr. Lee, what are your final thoughts tonight?
I think for patients, for providers, I think for payers, and in the payer space, I say both self-insured employers, which is the big chunk of this country, I'm excited about healthcare. And I'm excited about what these models mean and what they speak to. We talk about healthcare, and I'm a glass half full type of person. And Churchill said it, and this is my favorite quote: Americans will always do the right thing after they've exhausted all other options. We now are in a space where we are really using policy to drive sort of behaviors and beliefs that I think are really good for the patients in the community. They're good for the payer, the providers, where there's less burnout, and I think it's good for the payers as well, whether it's a social payer like the government or a private payer like a company. So this makes this country strong, and it will make it even strong as we move forward and across the sector. So we really get to do what we were trained to do. So I'm excited. I'm excited about this discussion. I'm excited that you guys organize this in such a sophisticated way to get this message out there. So thank you.
Thank you, Dr. Lee. And Dr. Kane, what are your final thoughts regarding tonight? But I'm gonna need you to slide a little bit over because you drift over too.
Let's just be getting relaxed and listening and learning. Well, let me say a couple of things. I want to make sure people are understanding that value-based healthcare has, at least in this case, we have two components. One in which we have the patient voluntarily enrolls themselves into it in terms of the direct primary care, a direct patient care. And then the other one in which they may have either insurance providers that are either governmental or public. Okay. And so that, but, and both of these individuals in their space provide excellent care within those models. And there's excellent future for both models. What we have to remember is that the benefits overall with direct value-based care, then the benefits we're looking for is decreased costs, increased time patients spend with patient-physician interaction, increased patient satisfaction because of that, and reduced medical errors with all these patients because knowledge is going to be shared. And then also it increased the number of informed patients. Patients, that's part of the problem, part of the thing that's needed for value-based to be successful. There is both entities will have shared responsibility. The patient and the provider, the care provider. The care provider offers this knowledge and yada, yada, yada. The patient's got to do their best as doing what's best for them. Put down that Twinkie, put down the Dunkin' Donuts or whatever the hell it might be, and be responsible to whatever degree to their own health in any model you choose. And for value-based to be successful, you've got to have patient participation. Ms. Turner, you know yourself, you've said on this program many a times that you decided to take your health into your own hand as it relates to, and I can say it because you said it, as it related to the threat of diabetes and the other health issues that bothered you, and you grabbed it by the collar, and you are now in control, as we speak today. Okay, so anyway, coming up, the next program, like I said, is going to be, and that's when the behind the scenes person is also going to be out there with us. Dr. Tyrone, call Tyrone at tyrone.net. Tyrone will come from behind the scenes because we're going to talk about things that in his field and other guests, the Internet of Things and how it relates to artificial intelligence, the role it's going to play with value-based medicine for Dr. Kenyatta Lee to make some decisions. It's going to assist him. It ain't going to replace him. It's going to assist him in making the wise decision, as well as it will with Dr. Jones, because that artificial intelligence is going to be able to analyze stuff at a moment, a drop of a hat, where we may have to take a lot more time to analyze that with the different formulas that are needed. But that's coming, and I hope people will join us in that next series, the next fourth Tuesday of the month. Or was it the last Tuesday? Which one?
Fourth Tuesday.
Okay, yeah, because I think it's 5 next month.
Oh, whatever. The last Tuesday is the good way to remember it. So thank you to each of the doctors tonight. As you can see, this is a very complex conversation and a lot to learn, a lot to digest. But the main thing that the doctor said is to do your homework. Don't wait for things to happen and as you make decisions about your health. And also, I just like to say, last week we talked about voting, the importance of voting. As you choose your elected officials, ask those tough questions, what their position is on assuring that everyone has health insurance coverage and the access to the doctors that they choose to have access to. Thank you all for listening
And
to
tell
the
a friend
show.
the same thing, Ms. Turner. Tell a friend what you just said in terms of asking those questions.
Thank you. Thank you, Dr. Kane. Thanks again, Dr. Jones and Dr. Lee. And thank you all for listening to Pause for the Truth. Stay tuned next Tuesday as we talk about another topic that's important, not only for you, but your family. And don't forget to invite your family and friends to join us, because I promise you, you will learn from the show. Good evening.
Good night.
Thank you.